Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. And it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals, maybe people that you've never talked to before or met before. But the goal is to really help you understand how to access care when you need it. This program is really for you. So if there is something that you want to learn about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Hello and welcome to this episode of Bristol Health Cares. Today we are going to talk a lot about home care hospice, more about hospice, as November is Hospice Month.
It is.
It's Hospice Month, right? Mm-hmm. And with me today as my guest is Robin Stasko.
Stasko,
thank you. Mm-hmm. And she is the manager of our home care hospice at Bristol Health. Robin, welcome.
Thank you.
It's so great to have you today.
Thank you very much. I'm happy to be here.
So tell us a little bit about yourself.
Okay, so I've been a nurse in the state of Connecticut for 41 years, and I have been in hospice for 20 years. I love nursing, and hospice is a passion of mine. And I'm so glad to be here to talk to you about any questions you have about hospice.
Yeah, so 20 years.
Yes.
First of all, congratulations on all those years.
Thanks.
As a nurse. It's really incredible.
Mm-hmm.
So the transition to hospice,
Yes.
what made you go from, so you did IV, med surge, ICU, you were everywhere, but you made that transition to hospice. What caused that?
That's a really good question. Nothing happens by accident, right?
Yeah.
And so as a nurse in the hospital setting and on the IV team, and I did a lot of home infusion, the natural progression is that some of these patients declined and came to the hospice type of care. And we realize that sometimes there's just a better way of being able to care for a body that is failing rather than treat, diagnose. Yeah. There is a more comfortable, peaceful way to proceed with end of life. And that it just became something that I cherished. I had a lot of really great mentors, and they, some of our best doctors and nurses are previous ER and ICU people.
Yeah.
So they see some crazy things happen to people, and they think there's a better way to handle passing, death and dying.
Yeah. So it's like a calling. It's almost like
is.
You see it and
Yes.
you see the opportunity for, we can do this better. And,
Yes.
and you go through that. And I, honestly, having, at my age, parents that went through with and without.
Yes.
Tremendous difference.
Yes.
I mean, it's, the dignity and the interaction with the family, all of those elements, become very front and center.
Yes.
And it's not just convincing the person to do
Correct.
it. It's ultimately getting that person to accept all that it is, which is where the role of the hospice nurse comes in, right?
Right. It's an art and a science in a sense, because I never want to convince somebody, but I am there to support and educate them so that they are making a really good decision. And if they're not ready for us, I say to them, you just may not be ready, but if you change your mind, you know how to call us. A lot of times when we get referrals, one of the newest steps that I'm taking is I'm calling the family or the patient individually and having that conversation. And I'll say to them, do you know your physician has made a referral to our department? And sometimes I don't even use the word hospice. I don't need to, and I say to them, and they say yes or no. And I said, do you know what that means? Do you have any questions? And they usually have a list of questions, and we talk it out, and I tell them the process. The other thing that I asked them right away is I said, are you having any uncontrolled symptoms right now? And they say, like, well, what's that? And I say, well, no hospice patient should ever have any uncontrolled pain, respiratory distress, nausea, vomiting, diarrhea, anxiety, agitation, or God forbid, constipation. It's like my mantra.
The thing we don't really talk about.
Right.
Except when you're on vacation.
Right.
I think people talk about it a lot. But
so I want to interview them a little bit to see how, if they're on board, and how fast we need to get out there. And so it kind of sets the tone for the consents, because consents, we can't force anybody to be a hospice patient. They have to elect it. And that's a serious commitment. And when I say to them, you realize that we won't be going back and forth to the hospital and back and forth to the doctor for testing and that kind of thing in general, they either are surprised by that, or they're like, no, that's perfect. We don't want to go back and forth anymore. So, it gives a really good opportunity to kind of lay the foundation for the admission. So the admission is really, really important, because they are signing consents. And if the patient can't sign the consents, their loved one is, their power of attorney, or their, the person that we designate. And then we're setting them up for what to expect. The hospice is a philosophy of care, of how to take care of somebody when they have a disease that we can't fix anymore. And it's a team approach. And the team starts with the patient and the family. They're part of the team. But it also includes the nurse, the medical director, the chaplain, the social worker, the home health aide, and the volunteer. And that's the big team that surrounds these people. So I like them to know it's a team approach, and that we're all part of the team, but it centers, the patient is the one guiding the need and the care.
So generally, when somebody gets to that point, the time frame, people kind of, they're always asking their physicians, how long do I have? How long do I have? And, in a lot of respects, science is science, but it's an art too. I mean, physicians and even nurses have a sense of looking at a person. They can often have a sense of what that means, or, parameters. But generally speaking, how long is it that a person, could be going into hospice before?
That's a really good question. People are afraid of us because they think if we walk in their house, they've got 2 weeks. And if we start using some of those important meds, that they've got 2 days. And that's a very strong misconception. The general guideline, according to Medicare, is 6 months or less. And what I say to families is every disease process has a different trajectory of time, so that an end-stage cancer patient may have a different journey than an end-stage dementia patient. And even if we hit that 6-month mark, as long as we are seeing declines, we can keep you, according to Medicare. That's a really good question.
Yeah, I know of many people, and you mentioned, people on Alzheimer, at the end, and it seems like, well, with both cancer and other, diseases that are now, would cause somebody to be going into hospice, the advances, like with Alzheimer drugs, and it's just amazing.
It is.
So 6 months could turn into a lot more than 6 months. It can.
So that is our longest disease process. They're usually on service with us longer. And I also like to educate people and say that, let's pretend it is Alzheimer's that we're using, or dementia that we're using. A patient doesn't pass away from that disease. They pass away from a complication of that disease, which includes things like infection from aspiration, falls with injury, fractured bones, skin breakdown due to weight loss, malnutrition because they're just not eating the way they used to. And that's what the body does naturally. It's actually designed to work in that way. We give it a name, a diagnosis, but it's the slow, most people, it's the slow, steady decline in their body that is what causes it to pass away.
So the person that enters into hospice and does so knowingly, willingly, assuming they have cognitive ability and it's not somebody doing it for them, how does it feel different to them? You know, and I mean, it's a big question because everybody has a different
Yes.
feeling about it. But in general, because you spend time with them, what reflections do they give to you about the journey?
Hopefully they feel, a lot of them will say they are just relieved. They've made this big decision, and that big decision is over, and now they're going to sit back and be comfortable and participate in this type of care, which really includes, instead of looking at how long am I going to last, is enjoying every single day. And to start that, nobody can enjoy their day if they have an uncontrolled symptom, right? They're going to be miserable. We don't want them to be miserable. We want them to be happy. We want them to be enjoying everything they possibly can. So one of the first things we do is we look at maybe their med list that is this long.
Yeah.
And we say to them, you know, you really don't need all these vitamins and supplements, and you probably don't need your cholesterol medicine. I'd rather have you eat a cookie than swallow all these pills. And so I say that to them, and that makes them laugh.
Wow.
And I try to make them laugh. I want them to look at me as part of their team and their friend. I am their nurse, but I want to. But
you're also giving them permission to do things that they've been told that
their
not to do.
Right. So their doctor, you know, has been saying, you have to have this diabetes medicine to control your diabetes. Well, now we're saying you've probably lost some weight and you may not have the same needs that you had before when you needed your diabetic meds. And it's okay if your sugar is a little higher than normal, because it's okay. Yeah. So enjoy your ice cream and your, you know, and whatever tastes good to you, I want you to have that. So you enjoy and have fun in your day.
So very often it's, you know, the family members, the kids who are saying,
you have to have.
No, I'll never forget my mother-in-law, you know, was in hospice, and she's got 8 girls and 1 boy. Every one of them has her, you know, an opinion about what was going on. And and my wife was, you know, with her, and one of her other kids, she was living in their house at the end, and hospice was coming in. And as she approached the end, she said, I want a Bloody Mary. So they gave her a Bloody Mary. And then, you know, then the reaction became swift from others who saying, wait, what are you doing? You know, and they're not wrong, because they want them to sustain and live. Right. But the reality of what's happening says, why not?
Well, and so that's really funny that you say that, because of the dynamics in a family. And so in addition to taking care of the patient, we also take care of the family, which means we have to get, as you know, we have to try as hard as possible to convince and get everybody on board. Do we make it all the time? No. Yeah. But we try. And so sometimes, you know, sometimes it's the long distance relative who hasn't seen the patient in a while that's got the biggest voice. And we just have to work with the group. And they're all at different levels of acceptance, right? And so we have to work with what we have. We may not get them where we want them to be ultimately, where we want them to be, but we're going to get them to where they should be on their own terms. Yeah. And to accept this information, that's devastating. I mean, we walk into people's homes on the worst day of their life, really, honestly, and it brings me a lot of comfort when I can get somebody settled and comfortable, looking peaceful, and the family's all on board, and they understand what they're looking at, and they're not as frightened anymore of what's going to happen next.
Yeah. So. It's, you know, and I've been through a couple of these experiences, and one of them in particular, the individual was really fighting because feeling like, I need to hang on, I need to do this, I need to do this. And finally, the spouse said, it's okay. It's okay. It's all right. And literally within, you know, moments, they let go. Because I think if I've learned anything about our environment is that, you know, faith, people's will and determination, having goals. I want to be at this person's wedding or this birthday, milestones and everything else. Actually it can make a difference.
It can make
people can will themselves to die, and people can will themselves to live.
Yes.
And I think that's one of the gifts of
the
you being a
mystery
nurse.
of
I'm
it.
not a nurse. I'm not a clinical person, but I see it and I believe it. And so it's so important to have all the spiritual pieces together.
Definite.
And honor that. But dignity, I want to, the other big question that you probably get all the time is, I want to be at home. This is my house. I want to be a part of this.
Right.
And then you have others that say, I don't want my spouse to remember me being in this bed. I want to be here. And so it's very individualized.
It is. And we ask those kinds of things upon admission and as they are processing this to help them make plans so that if they want to be home, we create an environment where we might eventually put the hospital bed. Is it a place where people can come and visit? Is there enough room? Is it comfortable? Is it feasible? Who's going to be taking care of the patient? Frequently, the best place for a patient is in the living room, believe it or not. There's lots of room. Visitors can come. They have places to sit. If they don't want to be in their home, we have to talk to them about, okay, we need to start making plans. Where would you like to be? These are your options. Here's the question. Here are your options. Which one would you like to do? So that our goal is that it should never be any more emergencies. The emergency is over. We've made the decision to choose hospice and that we want to set you up for success. And that means not calling 911 anymore, the bells and whistles, no. We don't want you in an ambulance going into a cold emergency room. We need to plan this out. So we had a patient just recently, he was just not doing well and we had to get him to his next destination. And he is comfortably transitioning and on his way. He knew he couldn't stay in that apartment and we made the arrangements.
Yeah.
He made his choice. We got the bed. We transitioned him. That's critically important. So no more emergencies. Do emergencies happen? Yes, they do.
Sure.
But we are trying to prevent that from happening as a goal.
So I always wondered about people that do what you do and how they kind of regenerate, especially. So I worked at Fox Chase very early on in Fox Chase Cancer Center, and I was a transport, so I would get back then. I'm dating myself, in the late 70s.
Yep.
Patients stayed forever.
Yeah.
So even myself transporting them back and forth to radiology for tests and everything for months and months, you couldn't help but get attached to
Correct.
these patients. And it just occurred to me as you were talking about how you make their environment better, and you really do. The goal is to have this, no pain, none of those other things you listed, and happiness, and to be able to say goodbye in a very appropriate, positive way. Is that the source of how you manage the other part of it, which is dealing with loss all the time?
It is. It fills me up when I can be present to watch them peacefully pass away. That's a very spiritual visit. Yeah. When you are watching somebody actually passing away, I feel like it's an honor and a privilege to be there. Sometimes we're not always there, and there are definitely some patients that touch us more than others. I can still list off a name of people that I will never forget, and the care that I provided, and the families that I've met, and that's what keeps me moving in a forward direction. And there are times when we do get tired. There's no doubt about it. We're going into a pretty busy season right now, and we're going to anticipate a lot of referrals and a lot of sad families through the next set of holidays, because people will say, oh, it's my last Thanksgiving with my family, and that makes them very sad. So we'll get an influx of referrals right about now. We'll start with that, and it'll carry us through, and we'll be busy. And we'll take a breath in January, it'll kind of even out a little bit, but there are cycles to the year. And my team is fantastic, fabulous, wonderful human beings, and we have to support each other. So if we see somebody looking a little worn around the edges, we we do wonderful things at our team meeting, or, we might have a breakfast, or we might lift somebody up and praise them, or say, why don't, do you need a day? Do you need to take a day? That kind of thing. And I'm always looking for that in my team, because they're working hard, and no grass grows under their feet. I'm going to tell you that right now. They are going strong.
So we can't take care of patients unless we take care of each other.
Correct.
First, and that's really a key takeaway. So I'm going to ask you one more question, because I've had to deal with this in my life. And I know other people, sometimes when you say it, people have opinions about being there at the end, right? And, I was there for both my parents, and I had, I walked away thinking, like, is that the picture I want in my mind, or not? And, so I've kind of vacillated about it, but I don't think there's a right answer.
There isn't a right answer.
Not everybody, if somebody doesn't feel comfortable, they don't have to be there. But I'm curious how you deal with that.
So I say to them in preparation, think about if you want to be present.
Yeah.
If you do, and you get up to go to the kitchen to get yourself something to drink and somebody passes away, don't take it personally. They may have done this intentionally so that you weren't watching them take their last breath. Or it may be the fact that somebody is traveling from across the country to get to you, and they're not going to pass away.
Robin, this has been incredible. I think we could probably talk for another day about this, because I think there's so many aspects of it that people, they have feelings as they go through the journey. And I think the key takeaway for me is, if you have questions, or if you're curious about the process and you have a loved one or even yourself, make the call. Have the conversation, right? I mean, that would be the most important thing is, there is a way to go through this journey at the end of your life that can be very, very different, and be very important in kind of like the memory that you leave for everybody that's following after you, that is going to keep your memory alive. So thank you.
Thank you
very much.
Oh, it's a pleasure.
So this has been an incredible episode of Bristol Health Cares. I'm Kirk Barwis. You can write me at cares@bristolhospital.org with your questions or suggestions. Again, that's cares@bristolhospital.org. And a big thank you to Nutmeg Studios. Nate, the whole crew here is amazing.
Yep.
I feel like this is, I was thinking as I walked in here, it's like, could this be like Abbey Road, like this special studio kind of thing? They have the most amazing equipment. And by the way, they are a nonprofit organization, so they really only exist through your charitable donations and support and grants. So please, 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 as you think about the holidays and your year end, if you have the means, please donate to Nutmeg TV. Until the next time, have a wonderful day.